Okay, and so we've started recording. Again, thank you so much for coming, and hopefully you will be able to see me now. Is anyone else joining via video, or is everyone only able to join by phone right now?
I'm on the phone.
Okay.
I'm on the phone as well.
I'm on the phone.
Fantastic. And then just to find out who is here.
My name is Rosa Gainey. I'm a certified diabetes educator for neighborhood health in Northern Virginia.
Great. Welcome, Rosa.
Thank you. Thank you.
Hello, everybody. Oh, sorry. Go ahead.
Sure. I'm Len Brennan in Maine.
Hi, Lenny.
Hi, Chris.
My name is Suparna Mahalaha. I'm part of Case Western Reserve University School of Dental Medicine in Cleveland, Ohio.
Oh, fantastic. Welcome.
Thank you.
So I think that's, as of now, that's all that we, all of the participants that we have. So today we're starting off with our learning collaborative and on integrating primary care and oral health and behavioral health for older adults. I'm going to share my screen, and then we'll also send the slides out afterwards. So in case you don't have access to a computer to see the information, and let's see. Sure, you don't want to see my messy email. And oops. There we go. And again, if you, or I should say, if you have any questions, please feel free to interrupt. What we'll be doing over the sessions is providing some didactic information and then discussion points at the end. And so, because it's also informal, if you have questions or wasn't about the material or something wasn't clear, please let us know. And Dr. Brennan, please jump in if I miss saying something that's important. So just to review, the Learning Collaborative goal and outcome is around developing a readiness assessment around health centers' readiness to care. And particularly with the lens of adults and integrated delivery of health care, primary care, dental, and behavioral, and also to look at the extent of provider training on integrative delivery for older adults with comorbid chronic diseases. And what we hope to come away with at the end is the beginnings of a readiness assessment toolkit for health centers as well as providers' integration readiness, and to share and identify best practices used in your partner health centers. So just to give you a frame of reference, the United States continues to experience incredible transformation in terms of the population demographics. Over 10,000 baby boomers are turning 65 every day, and they're the fastest growing demographic in this age group is women over the age of 85. And they expect that this age wave, or what they refer to as a silver tsunami, is expected to continue well into the next century. And you can see here, just looking at the data from 1900 projected to 2060, the number of persons 65 and older in the millions, and you can see the dramatic increase projected in the future. Additionally, thinking about where you are, this is a map of projected growth of seniors age 65 and older, and the projections are out until 2030, which I guess is not as far as I used to think it was. And you can see here in terms of the percentage growth that a lot of the states are expected to have 76 to 100% expected growth across the country. So for the conversation today and then the ensuing conversations, really wanted to set the context, and a quote that was in the White House Conference on Aging that was held in 2015 is from the SCAN Foundation, where they said targeted care coordination is the cornerstone to improving care while lowering costs. And while they were talking about long-term care and supports, we can think of it in care coordination in an overall manner. So today we're going to talk about aging and common chronic medical conditions. Just to set the stage, talking about the normative aging process, common chronic medical conditions for older adults, and chronic comorbid conditions, particularly with the lens of medical, dental, and behavioral, and the role polypharmacy plays. And then also to talk about some of the ideas around caring for older adults with chronic comorbid conditions and what you are currently doing in your health centers. So by 2030, as I had previously mentioned, the number of Americans age 65 and older is projected to reach about 71 million, nearly 10 million of whom will be 85 years and older. In general, seniors report better health, greater wealth, and higher levels of education than seniors in the past decades. So trying to understand the aging process, and generally as we age, there's a slowing down of systems, and this can vary greatly among individuals, and it's influenced by genetics, environment, lifestyle factors, and there's several theories of aging with respect to whether it's programmed and how it's programmed, or if it's more wear and tear. And so when we talk about understanding the aging processes, we think about aging processes with respect to biological age, which is the relative age or condition of a person's organ and body system. We talk about psychological age, which refers to a person's individual's adaptive capacities. We talk about social age in terms of their habits and their roles relative to the societal expectations. And then we also talk about legal age in respect to chronological years and the processes that are in place with their legal age. And then lastly, functional age in terms of comparing people physiologically to others who might be of similar age. So when we talk about the physical changes of aging, you can see here we have many different organs or senses and the aging-related changes. So for example, with the heart, aging-related changes are that we see that there's a decrease in the pumping effectiveness. With muscles, we get a muscle mass decrease. Within the brain, we see some loss of cell structure and function. Our skin becomes more dry, it's slower to heal, it loses elasticity, and our kidneys become less efficient. We have changes in vision in terms of depth and color perception as well as peripheral vision. We tend to lose acuity in our hearing, especially for those in the higher pitch range. And then I think probably one of the things that people talk about often in aging is the reduced bone density, the ability, the breakdown of our joint cartilage, making mobility an issue, and also our decreased taste buds and salivary production, which for those of you in the oral health field know can play a big role in terms of an individual's oral health status. And then lastly, urinary issues, the bladder capacity is diminished, which can have impacts on needing to take frequent bathroom breaks, and then in the lungs, the vital capacity declines as well, so that breathing may become more problematic over time. So in addition to the physical changes of aging, we also see mental changes in aging. And most people believe that memory decline is a normal part of aging, but while it tends to slow with age like the other functions, the other physical functions, the decline in the ability to remember is still there. It's just a bit in a slower process. So most of the individuals 65 and older do not experience severe cognitive impairment as they age. We experience some cognitive slowing. And as discussed previously in terms of physical changes with the brain, there are detectable changes in the brain. Its weight declines, blood flow diminishes, the nerve conduction slows, and nerves can even experience cell death. And so cognitive abilities decline gradually with these changes, but they tend not to affect overall function or activities for daily living for a large part of the population. While one of the things that can be impacted, of course, is that it takes us a little bit longer to retrieve the information that we're looking for, in as well as learning. While we can acquire information fairly quickly and retain it when we were younger, it takes a little bit more effort to process and store and retrieve the information as we age. So we can expect things to take a little bit more time. We might spend more effort learning, and we might have some difficulty in remembering something, but that eventually we would be able to get these tasks completed. There are aspects, though, where there is cognitive impairment, and cognitive decline has been streamlined into mild and major neurocognitive disorders. And these diagnoses come with subtype categories that include impairments consistent with neurodegenerative diseases such as vascular dementia and dementia of the Alzheimer's type, as well as other impairments, for example, substance medication-induced neurocognitive disorders. The most common form of dementia, as we are, I'm sure are aware, is Alzheimer's disease. It interferes with memory and normal intellectual functioning, and it has a staged progression, starting with forgetfulness and some bits of memory loss, and continues to progress with accelerated first-stage symptoms and restlessness, agitation, repetitive actions, to the final stage where there's loss of control with body functions and independence and complete disorientation. So in looking at that, are there actually hallmarks of aging successfully? And those who age successfully manage to avoid serious debilitating diseases and disability. They tend to function well physically, they can live independently, and they engage in most normal activities of daily living. And they've also maintained cognitive function, as well as they're able to be actively engaged mentally in mentally challenging and stimulating activities, as well as social pursuits. And so they're resilient and they're able to cope reasonably with physical, social, and emotional changes. So not to say that they don't have any of these changes, but they're able to cope with them a little bit better. And because of that, they have a sense of control over the circumstances in their lives. However, there certainly are people who may not be aging as successfully, and this is often the case with people who have common chronic conditions. Chronic disease later in life, so a prolonged health condition or a chronic condition is a prolonged health condition lasting more than a year. And it includes both, chronic conditions can be both physical conditions, for example, arthritis or cancer, as well as mental and cognitive disorders, for example, depression, substance addiction, and dementia. And oftentimes care is primarily aimed at managing the symptoms, preserving function, and minimizing future complications. And chronic conditions account for almost 75% of the U.S. Medical care costs, and its impact is not only on escalating healthcare costs, but also the quality of life of the individual, and they can have a substantial reduction in their quality of life depending on the type of chronic condition that they have, as well as the resources that they have to manage it with. So some of the common chronic medical conditions among older adults, and these are not in any particular order, but ones that I'm sure you've encountered: arthritis, and inflammation or wearing down of joints, has a prevalence of over 40 million Americans, and arthritis can impact loss of independence due to mobility issues. Hypertension or high blood pressure has a prevalence of around 30 million Americans, and it can lead to cardiovascular disease, stroke, blindness, and also can result in loss of independence or life. All of these things that, all of these conditions have consequences or impact in common, and that is oftentimes there's loss of function, loss of mobility, loss of independence, disability, pain, and if the condition is not well managed or at a far further stage before it's diagnosed, can result in mortality. Here's a list of the leading causes of death for adults 65 and older, and you can see these are ranked causes of death. And in this information from the National Vital Statistics reports, heart disease was ranked as the #1 cause of death, with cancer and chronic lower respiratory diseases following. And then you can also see that Alzheimer's disease and diabetes are up in the top 10 as well. And interestingly enough, that unintentional injuries is also in the top 10. That can be an antecedent to cause of death in this population. So in looking at chronic conditions, particularly thinking about multiple chronic conditions, you can see here that for adults 65 and older, about 30% have 0 to 1 chronic condition, and that the percentages go down with respect to a lower percentage of people having multiple chronic conditions, but even still, it's a pretty high number for those with 6 or more chronic conditions. An aspect that in healthcare that we're interested in, of course, is the spending. And so what are we spending for Medicare beneficiaries who have a number of chronic conditions? And so people who have, and for some reason the one did not get on there, you can see that there's differential spending depending on the number of chronic conditions that an individual will have. So in managing chronic conditions, in the Conference on Aging that was held in 2015, one of the concepts that came out is that the federal administration recognized the need for a culture change in how chronic conditions like arthritis, asthma, diabetes, and heart disease are addressed, and the need for a focus on supporting health. And so recognizing the impact of chronic conditions, not only on the individual, but also on healthcare costs and societal costs as well. They also talked about the idea of managing comorbid chronic conditions, and that it was really imperative to manage individuals with multiple chronic conditions. And that they actually have released a framework, the Multiple Chronic Conditions Strategic Framework for the healthcare system, to use in helping to improve health status of individuals with multiple chronic conditions. So oftentimes when we talk about multiple chronic conditions, we're often talking about physical or medical conditions, medical chronic conditions, but because of age-related changes in physiology and drug tolerance, older adults are also uniquely vulnerable to other health conditions, alcohol and prescription drug abuse, They can be more sensitive to the effects of prescription drugs, and they may also experience interactions with their other medications or chronic conditions. And so we also need to include behavioral health in terms of chronic health conditions. Particularly, behavioral health disorders such as depression and anxiety can cause distress and limit physical and social function, as well as complicate the treatment of other medical conditions. Unfortunately, older adults are usually less likely than younger adults to receive treatment for mental and substance use disorders. And so this is an area that the federal government has been developing more work in terms of understanding behavioral health in the context of overall health, as well as how behavioral health can be integrated into primary care delivery. So in thinking about comorbid chronic diseases, I wanted to just touch on a couple of approaches. And one that you might be familiar with is the shared risk protective factor approach. And the shared risk or protective factor approach really has at its heart the interconnectedness of health outcomes that have either root causes or resiliency factors or protective factors. And people who use this type of approach will use a framework of an ecological model that can examine these the interrelatedness of these factors and whether there's multiplicity of these effects. And they can look at it from many different slices, from the individual, through the individual's relationship, to the community in which the individual lives, to the higher society level factors. And this shared risk protective factor approach has been used in both looking at elder violence or elder abuse, as well as substance use and mental illness, and particularly talking about what health promotion strategies can be put into place at all of these different levels. Another approach, and this is in the dental realm, it was an approach that was developed by colleagues in the UK, and this is the common risk factor approach. So understanding that there are several common risk factors that cut across different disease states, and in this framework you can see on both sides we have risk factors, and in the middle we have diseases, and you can see that risk factors of diet and smoking and hygiene refers to oral health hygiene, stress and control or self-regulation and injuries can impact not only dental disease and oral trauma, but also obesity and type 2 diabetes, cancers, cardiovascular disease, and respiratory disease. And because of this, a common risk factor framework, whether it's this one from Shyam and Watt, or a shared risk factor risk and protective factor framework, really speaks to advocating for a multidisciplinary and integrated systemic approach where, if it's put into practice, may lead to better health care access, health outcomes, and reduced health care costs. So just an example of that is something that may be familiar with in periodontal disease and diabetes. And so there have been studies that have shown this bidirectional interaction, a growing evidence demonstrating the relationship between systemic diseases and oral health with the premise that, that periodontal disease and other systemic diseases have this bidirectional interaction. And previous studies suggest a strong correlation between periodontitis or inflammation of the gums and type 2 diabetes, and that diabetes is a well-known risk factor for periodontal disease. There's also evidence of periodontal disease's impact on glycemic control of diabetes patients and the triangular relationship between periodontal disease, diabetes, and obesity. So for example, periodontitis can be seen as a possible early sign of diabetes as well as uncontrolled diabetes. And the implication for this is that thinking about multidisciplinary integrated approaches, that a dental office or dental clinic that treats patients with periodontitis is potentially a suitable location for screening for diabetes of their patients. So in the remaining time, we wanted to open up to discussion because you are a wealth of information, and oftentimes in these collaboratives we find that the collaborative participants learn from each other, maybe even more so than they learn from the people who are hosting the sessions. And so we have a couple of discussion questions to ask in our remaining time, but I also wanted to open it up for any questions that anyone has. And if you have questions afterwards, please feel free. You can email us, and we can get information back to you. Okay, so I will start off and thinking about multiple comorbid conditions and potential for multiple drugs, as well as side effects from multiple prescribed drugs. How have you managed and tracked polypharmacy in your patients, and particularly your older adult patients who may have many different medications that they're on?
Chris, I can say that in the Motivate project that we're working on, we have like one of the first electronic records that integrate oral health to the medical record. And so what we have done is we have looked at the medications and the results of the medications and percent of xerostomia that you would get from these medications. It opens up then a very logical type of a treatment plan where we may have put them immediately on saliva substitutes, certain types of diets. So it has been very effective, and one of the things that it allows is the person who comes, the next CNA or the next nurse that comes in, they can follow what has been done and what's been working, and we get the best results of care from that.
Mm-hmm. Have you had the case where you may have had an elderly patient who has many different medications that because they have many different chronic issues and the medications have side effects like xerostomia, that over time more medications get added and more side effects, more medications get added to counteract the side effects, and so it's somewhat never-ending loop, and the patient's quality of life is somewhat decreased because of that.
I think the time intensity that when you look at a senior, especially in assisted or long-term care, one of the problems is that we're easy to add a drug instead of thoughtfully looking through the situation. A good example would be a patient that was called in to see with severe depression, and so they were adding, she wasn't eating, adding stimulants for appetite, and the issue really was her dental. So that looking at the two greatest factors for seniors is the ability to socialize and the ability to chew. So what happens, I think, the aids get pushed to a side, and it's easier to treat through meds than to thoughtfully think through it as an interdisciplinary team. So I think part of it has to be a thoughtful approach, and I know our system, our medical system, really doesn't have much time given to look through some of these records.
Mm-hmm. Okay, great. Thank you. Anyone else?
Chris, I'd like to know, there was yesterday at the CE class at Harvard, the continuing ed, there's a gentleman from Mexico, and Mexico City has, according to him, I'm not sure if this is correct, but the highest diabetes rate in the world. And when you're looking at long-term care, one of the things that happens is when you're losing your teeth and you have trouble swallowing or dysphagia and you worry about aspiration pneumonia, they give in protein drinks. So one of the things, tomorrow when I go back in and I chat with the group, I looked at the amount of sugar that they give to increase body weight, and it's surprising that some of these drinks have between 5 or 6 teaspoons of sugar to 20 teaspoons of sugar. So now we're increasing the weight, but we're doing terrible damage to the oral environment. So the interconnection is very, very important.
Yes, and I'm sure, Rosa, you would say that that's not good if they are in a pre-diabetic state as well.
Right.
Yep, yep.
So in thinking about the increasing population of older adults, what do you feel would be necessary to ensure an adequately trained workforce with the knowledge and skills needed to support this this population of older adults, particularly if we are also seeing, along with a larger number of older adults, we're also seeing more older adults with complex chronic comorbid health conditions.
So one thing that seems to be important is if we can, give our students more interprofessional opportunities, to learn from the different disciplines, medicine, nursing, social work, nutrition, so they can see how the different disciplines approach care, and just as dental students are involved in that setting, it's important for those professions to see oral health as a part of a team as well. And I think it really helps when they learn when everybody learns from each other.
Okay, thank you. How do you, so Rosa, I guess just to expand on what you had said is there a better place for training the workforce? Do you see a better place in their training trajectory in order for interprofessional education to really take hold and actually translate into the healthcare setting as well?
Well, I really think that any time that you can provide an opportunity for actual hands-on, it's a positive. Whether you're talking MAs or you're even talking about brand new nurses. But when it comes to when it comes to training, that should always be included. Plenty of time for hands-on to actually clinical experience, because we learn a lot in our in our courses and our. But I think that it is actually from. I think that one of the people that just spoke said it, that we we learn from each other. But definitely by actually being with the patient and taking the time to think through, not just giving something or pushing for something, but actually thinking on, okay, who is this person, where they're coming from, their perspective, but where do they live, their age, their everything, taking everything. And that takes time. That takes time, and a lot of times we're lacking the time in our clinical days.
And do you see that, this is kind of a closed-ended question, do you see that as an issue particularly for the older adult population where their history and their health issues might be more complex?
Well, certainly. You said it, with you were explaining it, our bodies age, and, if we're not aging successfully because we have these chronic conditions, then it makes it, it's a double whammy for the body functioning. And, yeah.
Okay.
Leave it. Yeah.
Great, thank you. So we have a couple more minutes. I wanted to just leave you with this last question, and certainly this is something that we'll continue to go back to over the next few sessions, and that is, what do you need to manage your patient's chronic comorbid conditions and to optimize their physical, cognitive, behavioral, and dental health? Any last thoughts about that?
I have one comment, Christine, that, I think for Maine, which is very rural, and for a lot of New England states, I think that education, interprofessional education, is really is key. I think we all need to be an access point for patients through our own discipline. So if we have patients that are at the physician's office or seeing nurse practitioners or physical therapists, a word about the importance of oral health in conjunction with what they're doing, so they relate the two, we know that that type of conversation will bring seniors into the dental office, and especially where finances are such an important access to care issue. If we have the perception of care, if it comes from a different access point, we're more likely to get them into the dental office. So education, I think, is going to be just key.
Okay, fantastic. So wanting to be respectful of everyone's time, thank you so much for hanging in there. Hopefully next time we will have no issues, technological or otherwise, and we look forward to continuing our conversation in the next session, and we will send you information about it prior to the meeting date. And so if you have any questions in the meantime, please feel free to reach out to us, and we look forward to hearing and maybe seeing you in a couple of weeks.
Thank you.
Thank you, Christine.
Thank you, everybody.
Nice to meet you all.
Bye.
Bye-bye.
Bye.
Hello.